Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Cristella, your host for today's episode, and we're going to be tackling another essential hematology topic, leukocytosis and leukopenia. To help us break it down, I'm joined by Reham Amin Saido.
Hey everyone, I'm Reham and I'm excited to be here. And in this episode, we'll explore what happens when the white blood cell count goes too high or too low, why it matters and what it tells us, and how to interpret it in real life.
Perfect. So let's start from the basics. What are white blood cells and why do we care about their numbers?
White blood cells, or leukocytes, are the body's defense soldiers. They originate from hematopoietic stem cells in the bone marrow, which differentiate into the myeloid and lymphoid lineages.
Right, so the myeloid line gives rise to granulocytes like neutrophils, eosinophils, and basophils, as well as monocytes, platelets, and red cells. And the lymphoid line produces T cells, B cells, and the natural killer cells.
Okay, here's a quick picture in words to visualize the white blood cells. Neutrophils have multi-lobe nuclei with fine pale granules. Eosinophils have bilobe nucleus with bright red-orange granules. Basophils have dark blue granules obscuring the nucleus. Lymphocytes have large round nucleus with a thin rim of cytoplasm. And for monocytes, they have kidney-shaped nucleus with a gray cytoplasm.
Nice, so those are like the main characters of the immune story.
Exactly. Now, let's talk about the white blood cell counts and distributions. The normal total white blood cell count in adults is around 4,500 to 10,000 per microliter, but it's higher in newborns and children. Also, not all neutrophils are circulating. They exist in 4 compartments. Marrow storage pool, where mature cells are waiting for release. Marrow proliferation pool, where precursors are dividing and maturing. A circulating pool, and that's what we measure in blood tests. And marginating and tissue pools, where cells adhere to endothelium or migrate into tissues.
That explains why neutrophil counts can swing so fast with infection, stress, or steroids. They shift between pools.
Exactly. Neutrophils live only 6 to 10 hours in the blood before moving into tissues for 1 to 2 days. Neutrophils have 3 main tasks, so honestly, it's giving cinematic villain arc. First is chemotaxis. They get attracted to microbes like villains sensing a protagonist. I smell trouble. Second is phagocytosis. They pull the microbe in like venom when he fully engulfs someone. 0 personal space, no question asked, just a crunch. Third is microbial killing. They just kill their protagonists.
So white blood cells aren't just numbers, they're active players in immunity with short lifespans but big impact. Okay, let's jump into the 2 big abnormalities, leukocytosis and leukopenia.
Leukocytosis means an increase in total white blood cells, usually above 11,000 microliter. Leukopenia means a decrease, usually less than 4,000 microliters. Both can be physiological or pathological. Physiological changes can occur with exercise, pregnancy, or stress. Pathological ones come from infection, inflammation, marrow failure, or malignancies.
Let's start with leukocytosis, when the body produces too many white blood cells.
Sure, let's start with the pathophysiologic mechanisms. There are several reasons this happens. It could be due to increased production in bone marrow in cases of infection, inflammation, or neoplasia. It can also be due to increased release from marrow storage pools. Also, it can be due to decreased margination, like after steroids or stress. It can also be due to decreased extravasation into tissues.
So you can have high counts either because you're making more, releasing more, or because the cells just aren't leaving the bloodstream.
Exactly. And the signals behind this are mainly cytokines like interleukin 1, TNF alpha, GCSF, GM-CSF, interleukin 5, and interleukin 7, each stimulating different cell lines.
And are there any classifications for leukocytosis?
Yes, we do classify leukocytosis based on which cell line is elevated. It could be neutrophilia, eosinophilia, basophilia, lymphocytosis, or monocytosis.
Let's talk more about neutrophilia.
Neutrophilia is the most common type of leukocytosis. It's defined as neutrophils above 7,500 microliters. The most common causes are acute bacterial infections and inflammation, tissue necrosis like myocardial infarction or burns, stress, smoking, or vigorous exercise, drugs such as corticosteroids, beta agonists, lithium, or GCSF, and in some cases, myeloproliferative disorders.
Now, here's something that often confuses students. When the white blood cell count becomes really high, how do you know if it's just neutrophilia or something more serious?
At first glance, a severe infection can make the count skyrocket, and it might look just like leukemia on paper. That's where the concept of leukemoid reaction comes in. It's an extreme but reactive rise in white blood cell count, usually above 50,000 microliters. It's triggered by severe infection, stress, or even inflammation.
And how can we tell that it's a reactive rise?
So you can tell it's a reactive rise because the blood film shows toxic granulation. Dull bodies and a high LAP score are all signs of active neutrophil response. In contrast, leukemia is a malignant process. Counts may be just as high, but you'll see blast cells, abnormal morphology, and a low LAP score.
So the takeaway is neutrophilia is a normal reactive rise, leukemoid reaction is an extreme but still benign response, while leukemia is an uncontrolled malignant proliferation.
Exactly, they all have the same lab findings, however, very different stories. Now, let's bring that to life. A 7-year-old presents with fever and productive cough. His white blood cell count is 18,000 with neutrophil predominance and a left shift. What is that, Cristella?
That's a classic bacterial pneumonia with reactive neutrophilia. If the count went above 50,000, we'd start thinking about a leukemoid reaction or even CML if blasts are seen.
Exactly. Always look at both the number and the morphology to interpret it correctly.
Next up, eosinophilia. Defined as eosinophils more than 500 per microliter, it's often summarized by the mnemonic NAACP.
N stands for neoplasms, A for allergies or asthma, the other A is for adrenal insufficiency, C is for collagen vascular disease, P is for parasitic infections. And the key cytokine here is interleukin 5, which promotes eosinophil production.
Next up, basophilia, which is rare but important.
It occurs in chronic myeloid leukemia, hypersensitivity, or hypothyroidism. So if you see increased basophils on a CBC, think chronic myeloid leukemia until proven otherwise.
Exactly. Now let's move on to lymphocytosis.
Okay, lymphocytosis mean lymphocytes above 4,000 in adults or 9,000 in children. And the causes vary. They include viral infections by Epstein-Barr virus, cytomegalovirus, hepatitis or HIV, bacterial infections like in pertussis or TB, others like thyrotoxicosis, drugs, and some malignancies.
All right, Reham, can you give us a case, please?
Sure thing. A 17-year-old girl presents with sore throat, fever, and cervical lymphadenopathy. CBC shows atypical lymphocytes. So what do you think that is, Cristella?
I think that's a classic infectious mononucleosis from Epstein-Barr virus. It's transmitted by saliva, and patients recover within 4 to 6 weeks with rest and fluids.
That's right. And remember to rule out cytomegalovirus and acute HIV. Also rule out toxoplasmosis and leukemia if symptoms persist.
And finally, monocytosis, which is less common but clinically important. It's usually linked to chronic infections like TB, endocarditis, syphilis, autoimmune diseases, and even malignancies.
And persistent monocytosis, by the way, always deserves follow-up, especially to rule out myelodysplasia or chronic inflammation.
Now to the other side of the spectrum, leukopenia, most often due to neutropenia. So can you walk us through how we usually classify it?
We classify neutropenia as mild, from 1,000 to 1,500 microliters, moderate, which is 500 to 1,000 microliters, or severe, less than 500 microliters, which correlates with a high infection risk.
But what can cause neutropenia in the first place?
Well, leukopenia, which also includes neutropenia, can result from either decreased production in cases of marrow failure, drugs, radiation, B12 or folate deficiencies, or it can be due to increased destruction, as in immune-mediated or severe infections. It can be also due to sequestration or margination like hypersplenism or septic shock, and also it can be due to infective hematopoiesis in megaloblastic anemias or myelodysplastic syndromes.
So always think, is the marrow not making them, or are they being destroyed or trapped?
Now, let's move on to a specific type of neutropenia, which is drug-induced neutropenia. Drug-induced neutropenias are actually quite common. Culprit cases include antibiotics like macrolides, vancomycin, sulfonamides. It also includes anticonvulsants like carbamazepine or phenytoin. It also includes GI drugs like sulfasalazine, valproate, and others like antithyroid drugs and antipsychotics.
So always review the medication list before panicking about malignancy. Now let's have another case, please.
A 35-year-old woman with ulcerative colitis on sulfasalazine presents with fever and mouth ulcers. Her ANC, which stands for absolute neutrophil count, is 300. What's that then, Cristella?
That's drug-induced neutropenia. Stop the drug, start broad-spectrum antibiotics, and consider GCSF for marrow recovery. But tell me, what else should we do for these patients to prevent complications?
We should isolate the patient if they are febrile to prevent secondary infections, since their immune defense is severely compromised. And the organisms we worry about most are quite specific, some of which include gram-negatives like E. coli, Klebsiella, Pseudomonas. Others are gram-positives like staph, strep viridans, or enterococci, or fungi like Candida or Aspergillus.
That's why fever in a neutropenic patient is a medical emergency.
Yep. And lastly, do not forget lymphopenia, where low lymphocyte counts are seen in HIV, corticosteroid use, Hodgkin lymphoma, or severe infections.
All right, let's wrap it up now. Leukocytosis is high white blood cells, mainly due to infection, inflammation, or stress. Leukopenia, however, is due to low white blood cells, usually due to marrow suppression or destruction. Always look at which cell line is affected and connect it to the clinical story.
And remember the key cytokines, interleukin-1 and TNF-alpha trigger neutrophil release. Interleukin-5 promotes eosinophils. Interleukin-7 supports lymphocyte production.
And that's it for today's episode of PodBites. We hope you now have a clearer understanding of how to interpret leukocytosis and leukopenia, and what they reveal about a patient's underlying condition.
Hope you enjoyed this episode, and do not forget to share it with your friends. Thank you for listening.
Until next time, stay curious, stay sharp, and take care.